Tropical Fluoride Dental Screening. County Collaboration. This presentation has been developed in collaboration with the health plans listed to the right, reflecting the collective efforts and contributions of all parties involved. Learning objectives. You are going to learn the importance of fluoride varnish, how it works, and its efficacy. Be able to identify patients that are high risk for dental decay, as well as how to apply it and aftercare recommendations. You will also learn how to answer any questions or concerns patients or caregivers might have. Who needs to be trained? All providers and staff involved in screenings, as well as those responsible for training others. Frequency. The training is required for all new hires and must be repeated every 4 years thereafter. What is fluoride varnish? As many of you probably remember growing up, gone are the days of using foam fluoride trays. We now have a superior product called fluoride varnish. As the name implies, the varnish or resin the sodium fluoride is suspended in is very sticky and adheres well to the teeth, allowing for an extended release time. A single application of fluoride varnish can decrease tooth decay by up to 2.5 times. Fluoride remineralization is the process of hardening the enamel by depositing calcium and phosphate mineral ions. So in this way, fluoride prevents new cavities and even has the ability to reverse small cavities that have begun to form. Fluoride also inhibits acid production and bacteria. Here's a fun fact to help educate you further and also to prove what an uphill battle it is to keep the teeth healthy and decay-free. Enamel is the hardest substance in the body, even harder than bone. So to think about the amount of acid exposure our teeth have to endure and then to end up with a cavity is pretty amazing. And part of the reason it's so challenging to avoid cavities is because there are 6 billion bacteria that live in the mouth, making mouths the second largest and most diverse microbiota after the human gut. A national survey from 2021 found that almost 15% of children ages 1 to 17 had decayed teeth in the past 12 months, ranking California 47th out of 51 states for poor oral health. And to compare that with more recent data, a 2023 analysis of the United States overall best and worst dental health took into account 25 key factors, and California ranked 41 out of 51. So nationwide, we're not doing so great in the dental health arena. A survey from 2006 shows that nearly 54% of California's kindergarten children and over 70% of third graders have a history of tooth decay. The national average is 33%. This chart may seem like outdated stats from 2006 to now, but based on one of the collaborative health plans' recent experience at schools in Shasta County and assessing children's teeth, those stats seem to be on par. Therefore, by kindergarten, about half of California's children have had decay, and 1 in 5 have had severe decay. Dental disease also ranks as the #1 chronic condition in children, surpassing asthma, allergies, and obesity. Statistics show that low-income populations have a higher risk of cavity experience. Another risk factor would be a history of decay or active decay. Although this may not be completely obvious in some children because their teeth have been restored with white caps or fillings. Start. Although this may not be completely obvious in some children because their teeth have been restored with white caps or fillings. In some children, decay will be more obvious because you may see untreated decay, dark spots, and or silver crowns, which are more easily identified than tooth-colored fillings. You can also ask the parent if the child has had restorative work done on their teeth before. Another big factor is frequent snacking. There are some obvious foods we think about when we think of cariogenic or cavity-causing foods like sugar and soda. However, even healthy things like milk can cause cavities because it has lactose. And that's the reason why baby bottle tooth decay is a problem. If babies go to bed with a bottle, that lactose is continuing to feed the oral bacteria throughout the night. Instead, babies should have a bottle before bed. Parents should clean their gums and teeth if needed, and then the child can have a pacifier. So, even foods we don't typically think of as cavity causing, such as milk, dried fruits, whole grains, and pasta, break down into sugar. And anything that breaks down into a sugar feeds our oral bacteria. Like any living thing that eats, it also has a waste product. Bacteria's waste product is acid. Acid weakens the tooth enamel, and then eventually a cavity forms. If we can break the cycle somewhere, we can stop cavity formation. For example, limit exposure time to harmful foods, stop the frequency snacking, or change it to a better option, properly cleaning their teeth, and drinking fluoridated water if possible. Regarding oral hygiene, often children only brush once a day, if that frequently. They should be brushing 2 times daily with the help of parents for younger children. Young children don't always have the dexterity to brush their own teeth independently. Think about this example. If a child can tie their own shoes, they probably can brush independently. However, it's probably a good idea to remind parents to look at their children's teeth and gums after they've brushed. Part of the reason California ranks so low on that previous slide for dental health is because there are areas in California that don't have water fluoridation. Providers, parents, and guardians should be encouraged to check with their local water utility agency, and households on well water should get it tested for fluoride to know the specific amounts. So we can assume anyone in areas with water fluoridation or who drink bottled water exclusively are at high risk for dental caries. The AAP recommends providers prescribe fluoride supplementation for those with fluoride deficient water sources, starting at 6 months of age until 16 years old. Providers are responsible for performing and documenting dental screenings and oral health assessments for all members. This means the child's mouth, teeth, and gums are inspected at every health assessment visit, and the child is referred to a dentist if no dental home is identified. Children should be seen at the dentist by 12 months or the eruption of the first tooth, or per AAP standards. Referral to a dental home should begin at 12 months old. If after 12 months the child still has not been established as a patient with the dental office, the provider should continue to provide oral health risk assessments and continue to refer. The reason we want children to find a dental home so young is because this establishes the child, hopefully well before they need any dental treatment, and it gets them used to a provider looking in their mouth. And the dental professional can give useful advice on how to care for their child's teeth. Oftentimes, parents think, they're just baby teeth. They're going to lose them anyway. And they do most of the time. It is possible for some individuals to never develop an adult tooth to take the place of the baby tooth. A patient could get a bridge or an implant if needed, but they could also get by with that retained baby tooth into their adult life if they take good care of it. And lastly, are our special needs patients. Depending on their circumstance, some special needs children might be very uncomfortable with close contact or stimulus. These children are going to be less likely to brush their teeth, allow parents to help, and cooperate in the dental chair. They may also be taking medications that cause dry mouth, and dry mouth equals no buffer for acid exposure, making their teeth more susceptible to decay. Where does this put medical providers in this scenario? Children see their medical provider sooner and more frequently than their dentist, if they even have a dentist. Therefore, there is an excellent opportunity to apply a highly effective cavity-fighting treatment for that child. Contraindications for fluoride varnish would be ulcerative gingivitis, which is basically really sore infected gums, stomatitis, which are canker sores that can be found anywhere in the mouth, such as on the cheeks, gums, or tongue. And if the child is experiencing enough pain associated with these 2 conditions, they will likely decline a fluoride treatment. Sensitivity to colophony, which is a pine tree resin, This is the equivalent to when somebody puts that they have an allergy or sensitivity to adhesive on their health history. With that said, offer the treatment and let the child and guardians tell you if they are refusing. The incident of reaction, even with an adhesive allergy, is very limited and should be evaluated by the practitioner. Fluoride varnish applications can be done at well-child visits, follow-ups, or standalone appointments. Generally speaking, a sick visit is not the time to do it. However, if they are coming back in for a minor ailment, please consult your practitioner. To start, we want to dry the teeth as best we can. Children especially salivate a lot, and they can make it more challenging to get the varnish to effectively stick on their teeth. The recommendation is starting on the lower arch and finishing those teeth as quickly as possible. As soon as the child tastes the flavor of the fluoride, they're going to salivate more. Gravity is going to cause the saliva to sit around the teeth on the lower arch. Therefore, recommend drying and painting the bottom teeth as quickly as possible, then drying and painting the upper teeth. Some sources say to paint all surfaces of the teeth. It is possible, just a little awkward. In dentistry, they apply fluoride on the biting surfaces and the outside surfaces. The tooth absorbs the fluoride so well that it's not necessary to paint all surfaces, and it can be challenging to paint what is called the lingual or inside surfaces of the teeth. If, however, you have leftover fluoride, time, and a cooperative patient, you're definitely welcome to, but it is perfectly adequate to just do the biting and outside surfaces. Oftentimes, kids will want to spit out after the application. It won't hurt them to swallow, but most kids won't want to. Be prepared to allow them to spit into a sink, paper towel, or trash can. Also, some parents report on a return visit that the child had a slightly upset tummy. Spitting after application or slightly reducing the amount of product being used on the teeth can help mitigate that problem. So, how often can we apply fluoride? The American Academy of Pediatrics recommends fluoride at least every 3 to 6 months, and those that are at higher risk, every 3 months. Consult your health plan for coverage questions. Now let's talk about patient positioning. If they're old enough and cooperative enough, they can sit on the exam table or any chair, or they're even welcome to stand. Have them tilt their head back and look up slightly. Also remind kids to keep their hands down or simply have them sit on them or put their hands in their pockets. For younger children that may need help from mom or dad, this knee-to-knee position is best. So, to recap, we're going to set up with our cotton gauze, trash can, or paper towel for the child to spit into and open our varnish packet. Sometimes it will separate, so just give it a gentle stir. Have the child swallow, or if available, use a cotton gauze to dry the teeth. Quickly paint the biting surfaces and outside surfaces of the lower teeth, and repeat the drying and painting process on the upper teeth. Lastly, allow the child to spit if needed. For a recap, some common questions caregivers might ask are, what is fluoride, or what are the benefits? The simplest explanation is fluoride is like vitamins for the teeth that help prevent cavities and can even reverse small ones that have started to form. You can even mention that American Academy of Pediatrics dentists and hygienists recommend it. They might say, my child just had a fluoride treatment at the dentist. Try to determine when the last treatment was completed and consult your practitioner. Along that same vein, they may say their child already uses toothpaste with fluoride in it and asks if it's necessary. Yes, teeth are constantly experiencing acid exposure, so they benefit from that extra strong dose of enamel hardening vitamins. Especially encourage it if the patient has a history of cavities. Can children with braces have fluoride treatments? Absolutely. Cleaning around the brackets isn't easy, so they definitely could benefit from it. Can they eat or drink afterwards? The short answer is yes, with a few exceptions. They can eat foods that aren't going to rub, pull, or melt the fluoride off the teeth. And that's just for about the first 3 to 4 hours. So no biting into an apple, celery, or carrots. Basically anything extremely crunchy like that. And also nothing sticky that will pull it off the teeth, such as gum, taffy, or caramels. If someone is in braces, they already can't bite into an apple or chew gum. So just tell them not to eat or drink things that are very hot, which most kids won't. For example, burgers and fries are fine, and they can eat those softer foods right away. If the fluoride treatment is done earlier in the day, they can brush their teeth like normal that night. However, if their teeth still feel sticky or tacky, skip brushing that night, but the child does need to brush the next morning. I'm sure you likely already experienced pushback from patients in other areas, so it probably doesn't come as a surprise that some parents may be hesitant about fluoride. If a parent says no to fluoride or thinks it's toxic, you're likely not going to change their mind. However, if they are open to discussion, you can tell them that any negative claims about fluoride are in regard to ingesting it in excess. All you're going to be doing is placing it topically on the teeth. Of course, the child may swallow a little bit, but it's not enough to cause any problems beyond maybe a mild upset tummy. If you want to go down that rabbit hole of fluoride toxicity, it is a possibility, but not a probability. In order for the child to reach the point of fluoride toxicity, they would have to ingest 100 times the optimal dose. This is likely only achieved through a child eating copious amounts of toothpaste. Areas of the world that have naturally high occurring fluoride in their groundwater, like India, parts of Asia, and Africa. But this isn't something that we've seen in developed countries. If fluoride were toxic, it probably wouldn't be recommended to go in drinking water, but it is. And studies show that drinking fluoridated water decreases cavities by up to 60%. Ingesting the correct amount of fluoride is most beneficial to young children because when the fluoride goes systemic, it builds into the enamel of their developing teeth. So the enamel of their adult teeth that are forming under the gum line become even stronger than their teeth would otherwise be without that fluoride supplementation. We hope this gave you enough information to feel like you know what fluoride is, what it's not, the benefits, and to really realize what a great preventative it is. Like most things in life, it's not a magic bullet, but it's definitely a big player in the world of oral health. So continue to encourage patients to eat healthy, keep their teeth clean, but also get their fluoride treatments. Thank you. Your participation is valued. Please share any feedback, questions, or concerns.